Welcome everyone to this ACP Problem Solving in Oncology webinar series. My name is Alistair. I'm a medical oncology registrar based at the Beatson in Glasgow, and despite the accent, I am one of the Scottish ACP training representatives. Thanks for joining us today. We've got a really good lineup of talks on treatment of both metastatic prostate cancer and also early prostate cancer. We're joined by Hilary, Glen and Dr Alison Tree, who I'll introduce a bit more shortly. So it's my great pleasure to introduce Dr Hilary Glen, who's going to be giving us the first talk on the topic of metastatic prostate cancer, specifically focusing in on the role of BRCA mutations testing and olaparib. She is a consultant medical oncologist based at the Beatson West of Scotland Cancer Centre in Glasgow, and I've had the pleasure of working with her in some of her clinics, and I'm sure that we're going to hear a really fantastic and interesting talk. So take it away and share your screen, Hilary.
Thank you very much, Ali, for the kind introduction. Thank you for inviting me to talk today. So the subject of advanced prostate cancer is absolutely enormous and too big to cover obviously in half an hour, as Ali can probably attest to. I could talk about it for days on end. So we've decided to just focus on this area of BRCA mutations in prostate cancer, and I'm going to talk a bit about the implications of that treatment and testing. This is quite a new and evolving subject in prostate cancer, so it's something as well, if you're in clinic, patients are starting to read up about and ask you questions about, and normally you have that kind of blank, oh, I'm just not quite sure what the answer to that question is. So hopefully this will help a little bit. So we'll talk about the implications of BRCA mutations in prostate cancer. I'm going to just briefly mention the mechanism of action of PARP inhibitors. I'm going to talk about the PROfound trial, which is the kind of main trial that's changed or opened up this opportunity for us treating prostate cancer patients. And then we'll spend a little bit of time talking about BRCA testing, the difference between germline and somatic mutations, how to do the optimal testing, and who indeed should we test. And then one little teeny slide if we've got time at the end, but we might not. Ali has already told me he's going to make me stop talking if I'm wittering too long. But we just did this small pilot study in my Ayrshire and Arran practice, where I have my clinical practice, looking at circulating tumour DNA, which has had some interesting results. So why is BRCA important for prostate cancer? Obviously, it's not something we normally test for, and it's not something we know a great deal about in prostate cancer, but increasingly we've become more interested about it, and we're realizing that it does have quite a lot of implications for our patients. So these first couple of slides are really thinking about patients who have a germline or inherited BRCA mutation. But essentially, prostate cancer with BRCA mutations, patients tend to present later. So on the left there, you can see the stage that people are presenting with the purple bars being people who carry a BRCA mutation, and the blue is if they don't. And what you can see is there tends to be a shift towards the more advanced stage at presentation in people who have underlying BRCA mutations. And if you look at patients who presented with non-metastatic disease, there's a far higher proportion who will go on to develop metastases within 5 years if they are a BRCA carrier. There's also quite a few characteristics, or I suppose a kind of phenotype that we're starting to see of patients where we think, gosh, I wonder whether they might have an underlying BRCA mutation. And it tends to be patients who present often at a much younger age than you would expect, and they often do have a family history. They've often got a high Gleason score, so 8 or above. Their tumour, their primary tumour, may be more locally advanced, so T3 or T4. There's often nodal involvement, and they're more likely, as I say, to have metastases at diagnosis. And what you can see in the Kaplan-Meier curve on the right is their metastases-free survival when you compare non-carriers with BRCA mutation carriers. And you can see they do a lot less well in the longer term. So that's of interest, but does it make any difference with how we treat patients? Well, of course, now we'll all have heard about PARP inhibitors, and we use PARP inhibitors, or we haven't, but in other specialities, specifically gynae cancers, in breast cancer. And just to remind you of what PARP does. So PARP is involved in repairing single-strand DNA breaks. So you've got your single-strand defect, and with the PARP will help fix that, so the DNA is repaired and the cell's all good to go. If you give a PARP inhibitor, then the single strand break isn't repaired, and it goes on and leads to the generation of a double strand break. Now, in normal cells, that double strand break can be repaired by this process called homologous recombination, or you'll often hear HRR, which is homologous recombination repair. And that then fixes the cell is good to go, and it survives. However, if you have got a BRCA mutation, you can't do this HRR, you can't do this recombination repair, and there is no repair, and the cell will die. So if you've got a cancer cell that has a BRCA mutation and you give a PARP inhibitor, the idea is obviously that the cancer cell won't survive and will die, and that's the basis of the treatment. So the PROfound trial was a trial of patients with prostate cancer. So these were patients who had metastatic castrate-resistant prostate cancer. They had disease progression on a prior novel hormonal agent. So usually that would have been abiraterone or enzalutamide. And patients needed to have progressed on that, and they also needed to have one of a number of qualifying genes that were felt to have a direct or indirect role in HRR. And patients were stratified according to whether or not they'd had a previous taxane and whether or not they had radiologically measurable disease. And they were split into two cohorts. There was cohort A, and these were patients that had BRCA1, BRCA2, or an ATM mutation. And the other cohort, cohort B, was all of the other alterations, genetic alterations that were kind of all lumped in together. And there was a 2-to-1 randomization in both cohorts. So twice as many patients got olaparib than were in the control arm. And the control arm was the physician's choice of either abiraterone or enzalutamide. Now remember that they'd already progressed through one of those drugs, and we know that retreating either with the same one or the other one is probably relatively futile. But I think people are often a little bit reluctant to have just a placebo-controlled trial, so that's what the control was. The primary endpoint was radiographic progression-free survival with independent review in cohort A, so in those patients with BRCA1, BRCA2 or ATM mutations. And then there were a number of key secondary endpoints, including overall response rate in cohort A, progression-free survival in cohorts A and B, time to progression, and then a look at overall survival. And just a wee note as well to say that patients were allowed to cross over, and there was criteria for who was allowed to cross over, which was you had to have radiological progression, no other subsequent anti-cancer therapy was planned, and toxicities from prior treatment had to be manageable. And they needed to obviously carry on with the study schedule. And so of the patients who were on the control arm, about 2/3 crossed over to ultimately receive olaparib. And there was a pre-specified analysis planned which adjusted for this crossover. So just quickly, a couple of slides about patient characteristics. So these are all patients, so this is cohort A and cohort B. About 250 patients received olaparib, and 130, just over, had retreatment with a novel hormonal agent. And they were fairly well matched in terms of where the metastases were, how many had measurable disease. People had generally had either enzalutamide or abiraterone, but obviously there was about 1/5 of patients who'd had both. And in terms of whether or not they'd had a previous taxane, that was well matched. As I say, that was a stratification factor, and it was about 2/3 of patients in both arms. These are patients with the BRCA1 or 2 mutation. So this is cohort A. And just to show again in terms of previous taxane use, there was a slightly higher proportion of patients who'd had a previous taxane in the olaparib treated arm compared to the control arm. And this was kind of the take-home slide or message, if you like. This was the primary endpoint, which was radiographic progression-free survival by independent review in patients in cohort A. So that was those that had BRCA1, BRCA2 or an ATM mutation. And what you can see is there's a really significant difference. So the hazard ratio was 0.34. That was statistically significant, and that equated to a median progression-free survival of 7.4 months versus 3.5 months. So a very significant difference in those patients. If we look to overall survival, and this is cohort A again, so this is just our BRCA mutated patients, again there was a significant difference between the two arms of about 19 months median overall survival in the olaparib arm compared to 15 months in the control arm, with a hazard ratio of 0.69. And if you then look on the right, when they adjusted that for crossover, because remember patients would have been crossed over, so a lot of patients went on to receive olaparib even if they started off in the control arm, you can see that the hazard ratio comes down to 0.42. So that was really very significant difference in terms of overall survival. If we look at overall survival in cohort B, so that's the patients with the other HRR mutations, there was basically no difference at all, and that was whether you corrected or not for crossover. So really there was no improvement in survival if patients didn't have BRCA1 or BRCA2 mutations. And this is just interesting. This was an exploratory analysis, so obviously we can't read far too much into it, but these are our patients with BRCA1 or 2 mutations, so cohort A. And if you divide them into whether or not they'd had a previous taxane or not, it does look as if those patients, obviously they did better, but you can imagine maybe they're a little bit earlier on in their disease journey, if you like. But there definitely did seem to be a bigger difference between olaparib and control arm if they hadn't had a prior taxane. There was still a difference if they'd had a taxane, but it was less obvious. And we'll come back to that point a little bit later on. And again, this was also an exploratory analysis of overall response rate. Now again, this was just in those patients, you'll see the numbers are quite small. So this was in those patients who had measurable disease at baseline. So clearly with prostate cancer, a lot of patients don't have resist measurable disease. But in those patients who did, there was a 44% response rate. Overall response rate in the olaparib treated arm, and no response rate seen, which isn't really surprising in the control arm. And just lastly, to talk about the most common adverse events that were reported, and certainly this is what we see typically with patients treated with olaparib. Anemia is definitely the most obvious, and that can often be quite significant, and patients often do need either dose reductions or transfusions to cope with that. Nausea is a bit of a problem, but not at particularly high grade. Fatigue also can be a problem. Interestingly, on this slide, we've not seen much thrombocytopenia, but in the patients, again, we'll come and talk about this a bit later, we've seen a bit of thrombocytopenia in some of the patients that we've treated. That probably is multifactorial, and if you think about some of the patients that we have that have got fairly advanced disease, and maybe if they've had lots of previous taxanes and they've got a lot of bone marrow involvement, their bone marrow is really struggling, and so that it tends to be one of the kind of limiting factors when we're using olaparib. So based on this trial, olaparib was licensed and in Scotland, so the SMC is who governs our approvals, and in October of last year the SMC approved olaparib as monotherapy for the treatment of adult patients with metastatic castrate-resistant prostate cancer who had a BRCA1 or 2 mutation, and that could be germline or somatic, which we'll talk about again in a wee minute, and if they had progressed following prior therapy that included a new hormonal agent. In NICE, it's still under review, and Alison might be able to tell us, so it's not available via NICE, but I'm not sure if there is any access to it on at the moment on the Cancer Drug Fund. So we just need to think a little bit now about BRCA1 and 2 mutations in prostate cancer patients. Who has it? And how do we test for it? And indeed, are we doing that? And the answer is probably around 10% of patients have an underlying BRCA mutation, and that could be BRCA1 or BRCA2 with prostate cancer. Now, that's based on what we know so far. It's not something we routinely test for. So this is based a lot on some of the data from Profound, actually, and some other studies that have been done, but we reckon it's probably around 10%. There is a difference between germline mutations and somatic mutations, and you possibly all know this, but this was kind of news to me when we started talking about olaparib last year, essentially. If you have a germline mutation, this is an inherited genetic mutation, and every cell in your body is affected with this BRCA mutation. So these are your patients that come from these BRCA families. So for example, breast cancer families that obviously are prone to getting breast cancer, and similarly men can have a BRCA mutation and they are then more likely to get prostate cancer. So family history is really important, and these patients, as we were discussing earlier, often present a bit younger with more aggressive disease. There's also something called a somatic mutation, and a somatic mutation is something that is acquired during an individual's life and only presents in the cells that derive from that mutated cell. So what we know is some prostate cancer cells just spontaneously develop a BRCA mutation and then go on and the cancer develops. So the cancer cells will harbour this BRCA mutation, but they won't have all their other cells affected by a BRCA mutation, because this is not an inherited condition. This is something that they have acquired in their lifetime that has led to the cancer. So if we test a prostate cancer sample, so an archival tumour sample, so when somebody has a biopsy and they're diagnosed, and then it goes into a paraffin block and sits on a shelf somewhere in pathology department, if you look in that prostate cancer, you can find a BRCA mutation. What you don't know is that a somatic mutation that has just arisen in those prostate cancer cells, or was it a germline mutation and they've actually got an underlying inherited BRCA gene? So as I say, 10% of patients will have a BRCA mutation. Only about half of those will have an underlying germline mutation. So if you only test patients for a germline mutation, so for example, if you send them to genetics to look for a BRCA mutation or an inherited BRCA mutation, you will miss about half of the patients who have a mutation in their prostate tumour, if that makes sense. Similarly, if you pick up a BRCA mutation in the prostate cancer cells, you don't necessarily know whether that patient has an underlying germline mutation. And that's important to know, and we'll come back to that for things like familial testing and looking to see if anybody else in the family is affected or needs to be tested. So, in terms of BRCA testing, what do we do? How can we test it? What tissue samples can we use? Is there a timing issue? Are recently biopsied tissues better compared to archival tissue that sat on a shelf for a few years? How old can the tissue be for testing? And are mutations likely to occur at a later stage of disease? So are you better testing a metastatic deposit compared to a primary tumour? So if we look at the Profound trial, about 4,500 patients entered screening, about 4,000 of whom managed to have a sample that could be tested. And about 70% of those had a successful tumour test. Now that does not mean that they had a BRCA mutation. That means they were able to sequence the genetic material of the tumour. And about 30% of patients, so about a third of patients, it was not possible to decipher if they had an underlying BRCA mutation or not, because they couldn't get that material. Patients were allowed to be considered for retesting if there was an initial fail, and a small number were able to get a successful test afterwards. But generally speaking, it was about 2/3 who had a successful sequencing of their tumour, and there was various reasons for test failure. But what you can see is, for the rather small number of patients that were in the trial, there were 4,500 patients that were initially entered into screening. So you have to, there's a lot of men that you have to test to find the patients that you can actually treat. If you compare newly collected samples and archival samples, there was definitely improved success rates if the sample was fresh and newly collected compared to archival tissue. And what you can also see on the right is if you look at the time from or how long the sample had been archived for, there was a definite drop-off in success rate of being able to sequence from that. And that's because these samples were just getting older and older and older, and therefore getting some proper genetic material to sequence was increasingly more difficult as the sample got older. And that's very important for prostate cancer men, because if you think about men that get a diagnosis, even if they're diagnosed with metastatic disease, they're often a number of years just on hormones before they become castrate resistant. And other patients will have a diagnosis when they've got curative disease and it's many years later. So a lot of our patients will have very old archival samples, which makes testing difficult. There was a slightly higher success rate in metastatic deposit samples, which was a small proportion of the patients compared to when they tested the primary tumours. BRCA mutations are felt to be very early and stable events, and therefore I suspect this result is not because more metastatic tissue has BRCA mutations in it, but it's probably just that they were fresher because it was probably a new sample that was taken from a metastatic deposit compared to the primary samples, which might have been sitting on a shelf for a long time. So probably the thing that makes the biggest difference is the length of time that it's been sitting there rather than whether it's a primary or a metastatic deposit. But remember what's very important, a failed tumour test is not the same as a negative test result. So you can have positive sequencing, so they've done a successful sequence, but there's just no BRCA mutation. So that's not a failed test, that's a negative test. A failed test is when you've not been able to sequence the tumour cells, and therefore you still don't know after the test whether the patient has a BRCA mutation or not. So who should we test for BRCA mutations? Ideally, everyone diagnosed with prostate cancer. We would ideally like to know from the beginning, have they got a BRCA mutation or not? That's good to know for familial testing. It's good to know for treatment going forward, what might options be. It's also, I suspect, like all these things, at the moment we're thinking about using olaparib in the castrate resistant setting, it may well move further up the treatment tree as time goes on, and therefore it's almost certain that we'd like to know as early as possible if somebody has an underlying BRCA mutation or not. I think where we are at the moment, and probably more realistically, we need to concentrate on those patients who've got metastatic disease rather than all comers. And again, due to testing resource, we probably are going to have to prioritise. This is really important because certainly when olaparib was approved last year in Scotland, we were testing nobody with prostate cancer for BRCA mutations. So where are we in Glasgow? Well, we managed, after much discussion, because it was a very difficult position when a drug had been approved for use in Scotland, but we didn't know who to give it to. And therefore we managed, through various freeing up of a small amount of resource, to agree that we could do some limited BRCA testing for prostate cancer patients. Now that's in Glasgow. I'm currently providing some cover in Dundee, which is struggling a bit from a staffing point of view. There's no routine testing in Dundee or indeed the east or the north of Scotland, as far as I'm aware. It's just in Glasgow. I'm not quite sure what the situation is in England. Alison might be able to tell us. So we've had to bring in these kind of false priorities, if you like, for testing, based really on we have to test somebody, and we want to be able to use this drug, and therefore we've introduced these, ideally we wouldn't have these restrictions, but we've had to introduce them. So men must have metastatic castrate-resistant prostate cancer. They need to have a previous biopsy or a prostatectomy specimen available. We have to not know already if they are a BRCA mutation carrier. Occasionally we have done germline testing before if somebody we think is at a particular risk of being a germline carrier. They need to have evidence of progressive disease on their most recent treatment, and they need to have progressed on ABI or ENZA or one of the other novel hormonal agents. And we are saying they need to have had a taxane. Now, as we've already discussed, probably we don't want to wait until after they've had a taxane. We probably want to treat them before that. But in terms of looking at patients and what treatment options they have, if they haven't had a taxane, at least they have that as a treatment option. So we're saying that they need to have that first, and then we can test, because we just simply don't have the resource to test everybody. What I should say is that since we've started doing this, which really has only been this year, our success rate is really low. We're not just absolutely clear for the reason for that. Although we've not been routinely testing prostate cancer specimens for BRCA mutations, we have been successfully testing, for example, ovarian cancer samples, and they have been much more successful in sequencing and looking for BRCA mutations. So the rate at the moment is somewhere around 20 to 25% successful sequencing, which means the vast majority of patients that we are even sending for a test, we're not getting a result back. So we need to improve on all of these things. This is just a note to say that if you find that somebody has got a BRCA mutation on an archival tissue test, and as I said earlier, we don't know if that is a somatic mutation or a germline mutation, then ESMO guidelines suggest that you then go and refer that patient to genetics for germline analysis, because if that patient, as I say, half of those patients will have a germline mutation, and we kind of need to know that because that has really important implications for the rest of their family, and they may then need genetic counselling about that. This is just a possible testing pathway that could be considered for our patients with prostate cancer. So you've got a patient with prostate cancer and you're thinking, this might be somebody I want to give olaparib to, or Lynparza. This is slightly modified from a AZ slide. So first question to ask, is there an archival or newly collected tissue sample available? If the answer to that is yes, then ideally, in an ideal world, we can send that off for tissue testing. And one of three things might happen. One is it's a positive test, in which case there is a BRCA mutation, and they are then able to have olaparib. We should, as I mentioned, then refer them on for germline mutation testing in case there is an underlying inherited BRCA mutation, and that patient should then be referred for counselling. Second possibility is they have a negative test. So successful sequencing, but they don't have a BRCA mutation. And that's fine. They don't need referred for germline testing, and they're not eligible to receive olaparib. The third possibility, which at the moment is the most common possibility, is that the test doesn't work. So we can't successfully sequence the patient's tumour for BRCA mutations. So what you want to do in that situation is assess why that might have failed, and see if there's any way of or a possibility of retesting or optimizing the testing. If that's not the case, you've a couple of options. One is maybe you could refer them for germline testing, because at least that will show up half of the patients and you'll pick up some of the BRCA mutations that are present. The other thing you could maybe do is consider an alternative type of sequencing, and that's, for example, circulating tumour DNA or liquid biopsy. Now, what you can see on both of those arrows is they've got a red line round them, and what that means is at the moment, certainly in Scotland, these are not things that are routinely available. We certainly can't do routine genetic testing because our genetic services are already totally overrun, and we don't have routine availability of liquid biopsies, but that's just something that could be considered in the future. If we go back to the start of the diagram, have they got a sample that's available? And the answer is no. Again, it really takes us back to the same as the patients who have an unsuccessful tissue test, in that is there another way you can do a test, for example, a liquid biopsy, or could you send them for germline testing? And if you can do either of those things, again, if they have a positive test, you could give them olaparib. Plus or minus genetic counselling. I think we're a long way off this, certainly in Scotland we are, but I do think we need to think about how we're going to manage these patients, because there is a treatment that is available and we'd like to be able to know how to do it. So this is my last slide, and Ali, hopefully we're not too over time. This looks a bit complicated, and what on earth does it mean? Before I moved to Dundee, temporarily, my clinical practice was in Ayrshire and Arran, because the Beatson covers kind of half of Scotland, so we all cover different geographical areas. And we set up a pilot study there with Foundation Medicine. So Foundation Medicine are a private company who do mutational analysis, normally at very great expense. But to cut a long story short, we set up this pilot whereby they allowed us to have 30 free liquid biopsy tests. And what that system is that you just have a blood test. So we don't need to send off any tissue. So if a patient hasn't got a biopsy, or the biopsy is really old, or it's not very good in terms of how much, you know what it's like, they've maybe got 3 cells in a wee Trussum biopsy from 10 years ago, it's going to be really difficult to sequence that. So they get a blood test and we just send that off to Foundation Medicine. What they do is they spin down the blood and they are able to extract circulating tumour DNA from that blood sample. Prostate cancer is one of the cancers that we know does release bits of tumour DNA into the bloodstream, and so you can extract that in the bloodstream. We could talk about this for a very long time, and I'm not going to. Suffice to say that there are clearly timing issues for this as well. We were able to do it on any patient we wanted, and there were some that we just didn't pick up any material at all, and that tended to be the patients who, for example, had hormone sensitive disease, that were on, say, abiraterone and LHRH analogue, and their PSA was fully suppressed, and those patients just didn't have any circulating DNA at all. The ones where you tended to find circulating tumour DNA were the patients who had quite a big disease burden, or were progressing, or had quite a high PSA. That rather suggested there was a lot of material to pick up on. So what you can see is a lot of chat here about ETF. So that is elevated tumour fraction. That's a kind of marker for how much DNA have we picked up from this blood sample. If ETF is present, that means there's a fairly good going amount of sample to pick up, and you can do the sequencing on that. And what you can see, so at the point of putting this slide together, we'd done 29 of the tests that we had. 25 of those had prostate cancer. We actually tested some bladder cancer. That's a discussion for another day, but that's interesting in its own. Of the 25 patients that we tested with prostate cancer, as I say, the majority had metastatic castrate-resistant prostate cancer, but there were a few hormone-sensitive diseases. 9 of them, there was a good amount of circulating tumour DNA, and of those patients, 2 had a BRCA2 mutation, 1 had a BRCA1 mutation, 1 had something called a PALB2, and that has been shown to probably be responsive to olaparib as well. They weren't included in the trial. The numbers are very small. We had to put a special request in for that. But that gave us 4 patients that would be potentially suitable for olaparib. If we then look at the 15 patients where there was less than ideal amount of tumour DNA essentially picked up for sequencing, in 8 of those we just couldn't pick up anything at all because there just wasn't enough material to test. But in about half of them, in 7, we were still able to pick up enough tumour DNA to do the sequencing, and we found a further 2 BRCA2 mutations in those. So if you can see down on the bottom right, what we found was that 19 out of 28 patients had successful sequencing. So that's nearly 70%. It's about 2/3 of the patients. That's on a par with what they did in a very controlled system of the PROfound trial. And it's also way, way higher than the sort of 20 to 25% success rate we're getting at the moment with our archival tissue sampling in Glasgow, certainly. And what we also found was 5 out of 24 patients had BRCA mutations in prostate cancer. Now, I've just spent some time telling you we think it's about 10% of patients that have BRCA mutations. Now, does that mean that in Ayrshire there's a lot more BRCA floating around? I don't think so, but what's interesting, like all these things, when we knew that olaparib treatment was possibly going to be on the horizon, I started keeping a wee list in my head of people that I thought they're the kind of person that you're worried they've got a BRCA mutation. Remember I was saying about the phenotype, they were young, they had a aggressive disease, they hadn't responded to much in the way of treatment so far, maybe they had a family history, whatever, and those patients were the ones that we tested first. So I think we'd probably cherry picked a little bit who we tested. And that, I think, on its own is quite interesting, because going forward, we might get better at picking the people that we kind of really want to test, because they've got more of the characteristics of somebody who might have an underlying BRCA mutation. Anyway, of those patients, we have been able to give some of them olaparib. Now, very sadly, none of them have done that well, and that is because most of them have had at least 1, if not 2, taxanes, they've got a bone marrows, they've really got end-stage disease, bone marrow stuff full of disease, they've probably had radium as well, and we're giving it to them too late. And as we could see before, although people were allowed into the trial if they'd had prior taxanes, it does look as if the earlier you treat these patients with olaparib, the better. So I think time will tell how we get on going forward, but I think there's some interesting things to think about from this. So I think that's me. There may be some questions from the chat, or you might want to ask questions later on, but I will stop sharing my screen now and pass you back to Alistair.
Thanks very much, Hilary. I didn't see any questions coming in through the chat. Ah, lovely. Dan's just sent one. So he says, thanks very much, Hilary. He's used foundation medicine, liquid biopsy in lung cancer before, and he was wondering about what we do from a governance perspective in terms of reviewing the reports in a molecular tumour board and how we might scale that testing up to a wider NHS population.
Yes, so that is a very good question, Dan, and I've got a meeting on Thursday up in Dundee to talk about BRCA testing. We are in a really difficult position just now because we've got a treatment that is approved and we can't test who to give it to, and that is really difficult. And I've also got lots of patients where I think I really want to know the answer here. There's a whole ethical dilemma as well. Do we even mention it to the patients, or do we just assume that they can't afford to go and get a private test? And of course, we should never assume these things. So people could go and get private testing. I also think that if we are actually just honest about it and acknowledge that we're maybe a wee bit crap at doing the test, and it's going to be an enormous resource to set up whole molecular profiling department to routinely test for this, should we just actually consider using something like foundation medicine to routinely do these liquids? It's a much, much easier way of doing things. Patients just get a blood test and you send it off. It does have loads of governance issues. We went through a huge amount of IT governance and information governance issues because obviously you're sending patient information essentially to an external company. So they need to be anonymised, but they can't be so anonymised that it isn't the correct patient that you're looking at the results of. And again, if we got some slightly puzzling results through or whatever, I was able to have specific discussions because this was a pilot study with the foundation medicine people, which was really helpful in terms of, oh, what's that and what does that mean and what's this? And we did that quite regularly. If you're doing it to the whole NHS as a wider population, it's very difficult. And yes, I think there would need to be some sort of way of incorporating these results into some, MDT discussion or some other panel, as you say, a molecular tumour board, if you've got that, or is it with just the oncology team? I don't know the answer. What I do know is that we need to start thinking about how we can routinely test for it, because we need to be able to use this treatment if it's appropriate.
Thanks, Hilary. There aren't any other questions that have come through the chat. I can attest that when you get a foundation medicine test back, you can sometimes get quite an overwhelming panel of mutations that you need to sort of sift out what you can do with, because cancer disease of mutations, so you're going to find them. I was just wondering, Hilary, ATM mutations were included in cohort A of the Profound trial, but as far as I can tell, they're not in the license for olaparib. Yeah. Are they patients that you'd be seeking to get onto olaparib if possible, if you picked one up?
So the short answer is no. And that's happened in a couple of patients. And I first of all had to chat with Rob Jones, who's our Professor of Medical Oncology and treats prostate cancer with us. And also, in fact, where Alison and I met recently down in London at the summit, the Janssen Summit, where there was lots of discussions about lots of things with prostate cancer. And I spoke to Gert Attard, who's done a lot of the work down in London with this. And I am not sure of all of the data because I don't think it's published, but basically there was a subgroup analysis, is my understanding, of the BRCA mutated patients and the ATM mutated patients. And when they went to get the license, they only got the license for the BRCA mutated patients. So I think basically there is no response, is my understanding, in ATM mutations, and therefore a license wasn't sought in that patient group, and there's no reason for us to try and get in individual patient requests for treatment for olaparib for patients who have ATM mutations. The opposite of that, as I say, I mentioned briefly, is the PALB2, which weren't included specifically in that cohort and is a very small number, but there is some work that suggests those mutations may respond to PARP inhibitors. So I would put in an individual request if I found a PALB2 mutation. And in fact, we've successfully got olaparib for a couple of those patients.
Perfect. Thanks, Hilary. And thank you for a really interesting talk. I think the idea of opening a can of worms by approving a treatment without a way of testing who should get it is an interesting lesson for us all. So we'll move on to our next speaker now, who is Dr Alison Tree, who is a clinical oncologist, in fact, who has very kindly agreed to join us medical oncologists to give us a talk on treatment of early prostate cancer. I think it's something that's really important. I think there'll be times if we do become practicing urology consultants where we may be sat in an MDT and our clinical oncology consultant is away and they turn to us and say, well, what should we do? So I think it's always important to know what we do in the cases that are treated by clinical oncologists for the most part. Dr. Tree is a consultant clinical oncologist at the Marsden and ICR and has been since 2014. She's got a special interest in urological cancers, but also particularly SABR and treatment of oligometastatic disease. So I'll stop talking now and please take it away and share your slides. Dr. Tree, thank you.
Great, thank you very much for the introduction and lovely to be with you. So I've been asked to speak about early prostate cancer and I'm going to stick to the topic. I'll start from the beginning, but we'll spend most of the time talking about prostate radiotherapy because that's what I do. Here are some conflicts of interest. And here is the outline of what I'm going to speak about for about half an hour, I think. So first of all, what is early prostate cancer? What are the categories that we can put patients into to help us find the best treatment for them? What are the treatment options for early prostate cancer? What fractionation schedule do we use for prostate cancer and why? And what trials are in progress and where, therefore, are we going next with the treatment of early prostate cancer? So this audience probably doesn't need to be told this, but prostate cancer is incredibly common in the UK, unfortunately. Probably when PCUK update their slides, this will probably look more like 1 in 6. It's an increasing incidence of prostate cancer across the population, but as you'll probably know, most particularly in men of Black and African origin, where 1 in 4 get prostate cancer within their lifespan, which is amazing, really. And these numbers are a bit out of date. This is CRUK data from quite a few years ago now. We think we're probably over 50,000 cases diagnosed each year and around 11 or 12,000 deaths each year from prostate cancer. It's the most common cancer in men, but most patients survive 10 years or more. This is for all patients of all stages, including early disease, of course. And as you probably know, there are no well-identified and scientifically robustly demonstrated ways of preventing prostate cancer. And it accounts for about 26% of all new cancer cases in males in the UK. And as I say, incidence projected to rise quite significantly. We've already seen that in the last decade, and that's projected to go on for the next decade at least. But there is some good news despite all of this. So the key messages in early prostate cancer are that sometimes it doesn't need treatment at all. And this is the most important thing because we don't want to give any treatment to patients who don't need it. If it does need treatment, some patients, or most patients, actually get a choice of modalities, and that might be radiotherapy with or without hormone therapy, androgen deprivation therapy. It could be surgery and it could be brachytherapy. If the prostate cancer does need treatment, there is a high chance of cure in early prostate cancer. So for the sort of intermediate risk patients, you're looking at about 90% control at 5 years after diagnosis. And with modern radiotherapy techniques, significant side effects are rare. And I'm going to go through some of that data in a bit more detail. So to put patients into categories to determine the best treatment for them, you need 3 key bits of information. And sadly, genomics is not one of those, although that may come one day. But at the moment, we rely on PSA, which is a blood test, as you will all know. We rely on T-staging of prostate cancer, which if you read the manual is a clinical T-stage. That means on digital rectal examination. But actually in the UK, we are lucky enough to have pre-biopsy MR, hopefully on nearly all patients nowadays. And so our staging really is morphed into radiological staging, quite rightly. And then the third bit of information you need, apart from the PSA and the T-stage, is the Gleason score, which is also called a grade group. So there was a slight refining of the Gleason grades, which have been around for decades, published by Epstein in 2016. And essentially, it's very similar information, and you can see in the table how the Gleason grades morph into grade groups. And I don't know what's happening in your centres where you're working, but actually I'm seeing a slide back to Gleason grades being reported rather than grade groups. So I'm not totally sure it's going to catch on, but we'll see. So this is just a very broad overview slide, just to give you the breadth of early prostate cancer. So on these are NCCN risk groupings. There are other risk groupings, but this is the one that I prefer to use. So on the left-hand side, you have low risk, so men with a PSA less than 10, early stage T1 or T2, and Gleason 3+3. And those patients, unless you've got a very good reason otherwise, should have active surveillance. In the second column, the intermediate risk patients here, so this is like top trump. So essentially you go into the box where your highest risk factor is. So for example, if your PSA is 15, but otherwise you're T1 and Gleason 6, you're still intermediate risk. So I hope that makes sense. But any of the following would make you intermediate risk. So PSA up to 20, T1 or T2, and Gleason 3+4 or 4+3. And for most of these men, you want to treat them. There is a cohort up down the low end that you might still be happy to give surveillance to. We certainly do survey some Gleason 3+4s, but the rest of them will get treated or get recommended to have treatment. If they are younger men, sort of 70-ish or below, then surgery is a reasonable option. Radiotherapy is always a reasonable option. I may be biased, but that's certainly the case, except for the very young men where you may prefer surgery, and I mean sort of those around 50. Radiotherapy is usually given with hormone treatments. And then brachytherapy, so implantable seeds for this group, or HDR brachytherapy, where you implant radioactive metal temporarily. These are all active radical treatment options for prostate cancer. And then we have the high risk group with any of these factors here. Surgery may have a role in the lower end of this group, but otherwise the standard treatment would be radiotherapy and hormone therapy. And then on the right-hand side, the right-hand column, this is the locally advanced patients. So T3B or T3-4, which is a slightly separate category. And these patients, excuse me, should get long course hormones and radiotherapy to the prostate with consideration of treating the pelvis prophylactically. And I'm not going to cover the next groups up, which are obviously node positive and metastatic. So I'm going to mention a couple of key trials through this talk. So this is PROTECT, which was a national treasure, really, a trial where the UK did what it does best and running these massive trials. So kudos to the trial team here. And the key to this trial success was by approaching a population of men and inviting them for a PSA screening test, but explaining to them that if prostate cancer was found, then they would be offered a randomization between 3 groups. And those groups were radiotherapy, radical surgery, or active monitoring, which was not active surveillance. It wasn't intense monitoring as we do now, but basically just sort of watching and waiting and doing a few PSAs along the way. And the most important part that they found is on the right-hand side here, which is that for this group of patients, which in this study were mostly low and lower intermediate risk, it didn't matter which one you chose. Your specific survival from prostate cancer was identical, whether you had radiotherapy, prostate cancer, or active monitoring. So this is more evidence backing up that active surveillance is a reasonable option. In fact, probably the best option for low-risk prostate cancer. But what this trial interestingly did do was demarcate the different side effects between these modalities. So surgery in the red line here and radiotherapy in the yellow line. And you can see the men who had surgery had much worse urinary incontinence scores, which didn't settle. So they remained at risk of urinary incontinence throughout. They also had worse erectile function, and interestingly, the radiotherapy group and the active surveillance group overlap once the hormones wear off. So there didn't appear to be a significant detriment of radiotherapy compared to surveillance in this trial. But there is a small risk to the bowels from radiotherapy. The magnitude of risk is less than that for incontinence or sexual dysfunction, but there is an effect of radiotherapy on the bowels. What about prostate radiotherapy then? So it's the commonest treatment used to cure prostate cancer in the UK, which is in contrast to many other countries. We treat almost 16,000 men, the last data we recorded, and we have a large number of radiotherapy centres in England and Wales treating prostate cancer. And it represents about a quarter of the workload of every radiotherapy department. For those of you who don't normally do this kind of thing, the patient lies on a bed. As I tell my patients, you don't feel anything. It's like having an X-ray taken. You just make the patient as comfortable as possible with a cushion under their knees and something to press their feet against. And then the radiotherapy is planned based on CT in the most part. We'll talk about the exceptions to that at the end of this talk. And the current standard treatment, what I do a lot of my life is draw around the prostate and draw around the seminal vesicles and draw around the healthy tissues of the prostate. Then my physics colleagues make a radiotherapy plan, which targets the dose where we need it and excludes the dose where we don't want it in the healthy tissues. And then the treatment is delivered based on implanted fiducials, so these are little gold seeds, or cone beam CT or MR guidance, which I'll come back to. And what you end up with is these nice pretty pictures where you can see the red dose, the dose that we want to cure prostate cancer, targeted exclusively over the prostate and a few millimeters around. And then the cool green and blue doses represent low doses, not likely to cause any side effects. So in order to plan radiotherapy, you need to know the T stage, just like you need to know for the NCCN risk. You need to know where the cancer is, I would say. We never used to take much notice of this, but actually when you're contouring a prostate, I need to know where the cancer is so I can give a bit more attention to my margin around that area. You need to know if the cancer is outside of the prostate, so you can include that area. And it's also helpful if you're not planning on MR to document the distance between the penile bulb and the prostatic apex, because that's not distinct on CT, so you've got no way of accurately telling where the prostate starts. So what is the optimal way to give radiation therapy? Giving you a bit of a history lesson here, so going back to the early days of radiation in the 1920s and 30s, there was one school of thought that said you should give one big dose of radiation once, and that would be the best way to try and cure cancer and would prevent the cancer having a way of getting round the tumour by recovering between fractions. And this was promulgated by Dr Vince, who sadly lost the battle, because in the blue corner we have Claude Rigaud with the counter view. He did some experiments on the rams testis as a model of using spermatogenesis as a model of cancer growth, and he found that if you gave one big dose of radiation, you still had spermatogenesis and the poor ram got very sore skin, whereas if you gave lots and lots of little doses of radiation, spermatogenesis was halted and the ram didn't get a sore scrotum. So this was the way that fractionation was born, and radiotherapy has been slightly rowing back from that ever since. And the reason for that is that the first clinical applications of radiation were in things like skin and head and neck cancer, where of course the tumour responds very well to fractionation. And so we assumed that all cancers were the same and that fractionation would be a good idea, but unfortunately what we know now is that some of the high volume cancers that are more deeply seated, so prostate, breast radiotherapy, many others, actually respond better if you give a lower number of higher dose fractions. And concurrent with this sort of epiphany of the last couple of decades, radiotherapy has undergone a technological revolution such that treatments nowadays are completely, you couldn't recognize radiotherapy from 20 years ago. It would be considered very basic technology. And in the same way that the phone in my lifetime has gone from this red phone box, if I needed to call home, to our portable Apple devices that now run every aspect of our lives, radiotherapy has undergone the same kind of technological innovation. I'm going to mention prostate SBRT as well. I'll come back to that in terms of the clinical trial data, but SBRT, also called SABR, is a non-invasive way of killing off cancer. It can be used anywhere in the body, but today we're talking about prostate, and it can be delivered in any radiotherapy department. You don't need a flash machine to do it. All of our machines can do this. And SBRT implies for prostate that we're giving a high dose per fraction, so 7.25 gray rather than 2 gray per day. For prostate, we do it in just 5 fractions rather than between 20 and 39 fractions. And we deliver the treatment very precisely with the best image guidance that we have available. And our physics colleagues use techniques to get the dose very high in the tumour and low in the surrounding tissue within a few millimetres. Oh, I was just to say that it's a stupid name because all radiotherapy is stereotactic. That just means fixed in 3D space, but we're kind of stuck with it now. The Americans were first out of the gates and started their SBRT program nearly two decades ago, which is amazing, and showed very good and encouraging outcomes for these early small series that they published. This was one of the first papers I ever published. This was just representing our early experience of prostate SBRT, and we were a bit late to the party, and I hope we've caught up since. So the data for prostate SBRT has evolved ever since. This was one of the first prospectively well-run clinical studies of SBRT, which was run across multiple institutes in the US. And I just wanted to highlight a couple of things from this terrible table, but this is, I'm going to highlight here the late toxicity. So this is grade 2 or higher bowel toxicity at any point between 3 months and 5 years after radiotherapy. And in this study of 309 men, only 2% ever got grade 2 or higher toxicity. As you can see on the right-hand side here, nobody got grade 3 or 4 toxicity. So incredibly low levels of bowel side effects all of a sudden. Sorry, I'm going the wrong way. And then just to move that up to the bladder toxicity, you can see here that was about 12%, which is actually what we expect. But you can see that the shift, the balance has shifted from bowels being the thing we worried about with prostate radiotherapy to bladder now being the key thing. There have been bigger series than this published, and these are sort of prospective how do you call it, just collecting of data, so pooling of data between series, and they've brought together 6,000 patients' outcomes, and have shown that there are very good cure rates after SBRT in a mostly good risk population. So this looks encouraging. But this is probably the most important slide that I'll show you today, and it's not actually about radiotherapy. This is looking at all of those series that you see in the literature where in the US, where they have their databases, NCDB and SEER databases, where they've got millions of patients due to their healthcare and insurance. And they look at what happens, say, if you do prostatectomy and what happens if you do radiotherapy. And they come up with these conclusions based on this observational data. And what this amazing group did is they went through these database studies and they paired them up with an eventual randomized trial that came along later. And they found 350 pairs of database studies versus randomized trials. And they found basically that the database systematically overestimated the effect of any intervention it was looking at. So only in 40% of the time did the database conclusion match the conclusion of the randomized trial. And I just throw this in to highlight the dangers really of relying on observational data rather than randomized data when you're trying to change a therapy. So not that long ago, 10 years ago or so, our standard radiotherapy fractionation for prostate radiotherapy was coming in every day, Monday to Friday for 7.5 weeks. And I don't know about you, but I feel fairly tired coming into work every day, and they pay me to come here. So you can imagine how the patients feel at the end of that. And so David Durnley led the CHIP trial, which is one of 3 trials which has changed the global standard of care for men with early prostate cancer. So this was the population included. So you can see from our previous slides, this was largely intermediate and a few high-risk patients. And they were randomized between our standard, which was 7.5 weeks of daily treatment, versus 2 schedules, which were approximately over 4 weeks. So one had one less day than the other, but essentially shortening the treatment course. And the headline from this trial, the CHIP trial, showed that 60 gray in 20 fractions was at least as good. And that's the red line here. And this is a Kaplan-Meier curve of biochemical relapse-free survival. And you can see the size of this trial, over 3,000 men randomized, a truly amazing achievement for the trial team. And so after this, 60 and 20 became the standard of care, which is across the UK and now hopefully across the world. But that's obviously one side of the equation, the efficacy. On the other side, the side effects looked much less than would have been expected. So you can see 2.9% have grade 2 or higher toxicity at 2 years. So these curves, these bar graphs rather, show the intensity of the colour is the severity of the symptoms. So here is 2 years after radiotherapy, and for the standard group and the 2 shorter groups, you can see effectively no difference in the toxicity. All of these light pink patients have 0 toxicity. The next pink here has grade 1 toxicity, and you can see very small numbers of men getting grade 2 or 3 toxicity at any point in their follow-up. And the other thing worth saying, going back to our Apple iPhone analogy, is that looking at 2 successive trials, so the RT01 trial, which was the preceding trial, and the CHIP trial, you can document how much the technology has impacted the side effects. So in the preceding trial, we used the same dose, so 74 gray and 37 fractions, and we saw that at 5 years, about 1/3 of men had significant moderate bowel side effects. In the CHIP trial, same dose, same schedule, we'd more than halved that rate of side effects with the same dose, same number of days. So the only thing that changed between these two trials was the technology and the techniques with which we delivered the radiotherapy. So we've managed to drop our radiotherapy down to 4 weeks, which is good, but that's still pretty tiring for patients. It's pretty expensive for hospitals to have the patient coming in every day for 4 weeks. So what more can we do? How low can we go with our radiotherapy? So there is already some level 1 evidence supporting that we can go significantly lower. This is the HYPO trial, which was run in Scandinavia. Over 1,000 men with intermediate or high-risk prostate cancer randomized to 8 weeks of daily treatment versus just 7 fractions spread over 2.5 weeks. And they've published already their 5-year outcomes, showing that the chance of being cured at 5 years is exactly the same, whether you have 39 days of treatment or 7. And so a lot of the Scandinavian countries have switched their standard of care based on this. Once again, we have to look at the toxicity. So there is a slight toxicity penalty. Now, this isn't SBRT as such because they used quite basic planning techniques. They used 3D conformal radiotherapy, which is no longer used in the UK, for example. And they demonstrated that the short-term bowel toxicity is worse with the 7 fractions, but that it settles down and there's no long-term penalty. There is a slight worsening of bladder symptoms after the 7-fraction treatment here in the red graph, and a slight flare of toxicity at about a year after treatment, but thereafter no difference. So we've been testing the same kind of hypothesis here in the UK, and many of you will have heard of or been involved in the PACE-B trial, which I'm going to mention now because we're just publishing the results. So the PACE-B trial recruited 874 men and randomized them to conventional radiotherapy, which could be given in either 4 weeks or 8 weeks versus SBRT. And these men in PACE-B were mostly lower intermediate risk patients. We kept very tightly to the safe accepted levels of doses to the rectum and the bladder, and this was very rigorously applied to make sure we maintained safety even while we were testing the 5 fractions. And we've published already that the short-term toxicity out to 3 months after radiotherapy is no different whether you have the longer schedule here in red or the shorter 5-day schedule in blue. So it makes no difference to your short-term effects whether you have your treatment in 5 days, 4 weeks or 8 weeks. And we're just publishing, and please don't tweet this slide for this reason, the long-term toxicity of PACE out to 2 years. And you can see extraordinary low levels of men getting either bladder or bowel side effects at 2 years after radiotherapy. Once again, the same kind of graphs with the dark green bars being no toxicity, light green being grade 1 minor toxicity, and the orangey colours being grade 2 or higher toxicity. So no difference between groups on those kind of metrics. If you ask the patient, so we do a lot of patient-reported outcome measures, this long questionnaire called EPIC 26, which asks about a range of factors. This is the bladder effects. You can see that at 12 months, there is a significant deterioration in bladder side effects for men getting 5 fractions. And that was reflected in some of the clinician-reported outcomes as well. And we can see that here at 12 to 15 months, there is a flare of toxicity we see with 5 fractions in urinary frequency, urinary urgency, and to a lesser extent in pain and dysuria, which flares and then appears to settle. And of course, we don't know yet what will happen after 2 years. But the bowel side effects are intriguing because actually on our doctor-reported scales, CTCAE and RTOG, we don't pick up much at all. But when you ask the patients, they do seem to feel that their bowels are worse in a way that doesn't get picked up on any of those other metrics. But overall, the summary from the PACE-B trial to 2 years is that in general, the bowel side effects are less after 5 fractions, so you actually make their bowel symptoms better. And the urinary symptoms are worse, I think. These are non-significant, are reduced p-values, but there's a clear trend that the bladder side effects are more prevalent, more frequent after 5 fraction SBRT. But the higher grade toxicities were vanishingly rare, maximum 0.3% grade 3 toxicity at 2 years, which is encouraging. Erectile function remains a problem after radiotherapy, partly due to the hormones usually, but in this trial there were no hormones. This is purely due to the radiotherapy, and it's impossible to know how much of this is due to the naturally aging population that we generally treat for prostate cancer. And what I can't tell you, I'm afraid, is the cancer control rates at 5 years. We're expecting that data to mature next year, and then hopefully we'll be able to benchmark if 5 fractions is just as good as 20 or 39 in controlling cancer. We hope so. So what's next? What trials are coming through and are going to change the landscape over the next 5 to 10 years? So we've just finished recruitment to PACE-C, which is a mirror trial to PACE-B, but in higher risk patients and with the addition of androgen deprivation therapy as well. So we actually recruited over 12,000 men in the end, and despite COVID managed to recruit ahead of schedule. And I'm very grateful to the whole of the UK for recruiting alongside us. But that's not the end of the story. We know men sometimes need pelvic nodal irradiation, and so the next question is, can we safely do that in 5 fractions? There is some published pilot data in small numbers. This is the series from the Sunnybrook team in Canada, showing that in their hands you can safely treat the pelvic nodes in just 5 fractions, which would be a big change, a big improvement. And so in the UK, our team led by Emma Hall, Angela Parth-Manathan and Sunil Jain, and funded by Prostate Cancer UK, will be doing the PACE Nodes trial, which is hopefully coming to a hospital near you soon, randomising men with high risk disease to prostate SBRT versus prostate and pelvic radiotherapy. And the other innovation that's coming our way is to put the dose where we really need it. It's never made any sense to treat the whole prostate to the whole dose, because we can see that some bits of the prostate have no cancer in on MRI, and some of them have a big blob of cancer here on this T2 MRI image. So the question is, why don't we put more dose where we need it? And that's what we've been testing in the Delineate trial at the Marsden. There is already high-level evidence from the Flame trial showing that if you boost the area where you can see the cancer on MRI, you can improve biochemical control significantly, in this trial from 85 to 92% 5 years. And this was in a high-risk cohort. So we're now getting our high-risk patients over 90% control at 5 years, which is a big improvement. And they've also shown in the Flame trial that this biochemical control advantage translates into something more clinically meaningful. So here, a regional or distant metastasis-free survival improvement. And this is likely to translate into an overall survival improvement in due course. And so we've published some of the outcomes from the Delineate trial, which is a multi-cohort trial of focal boost with different fractionation schedules. As I've just shown you, we've been on a journey over the last 10 years, so we've had to keep adapting this trial to keep up to date with our changes. And you can see here the cohorts we've recruited to, so A and C with a standard 2 gray per fraction, and cohort B with the current standard of care 60 and 20 with a boost up to 67 gray. And then finally cohort E, trying to test the same approach in just 5 fractions. So this is data for the 67 gray boost in 20 fractions, and this is the 2-year toxicity data. On the top we have the percentage of men getting bladder toxicity, and on the bottom bowel toxicity. And so you can see, considering we're putting a lot more dose into the dominant lesion, we're not getting a significant difference in the toxicity that we see. But what we are seeing is incredibly high rates of control. So this is the rate of progression 5 years after treatment. So less than 5% in all groups getting any sign of cancer returning. And despite the fact that most of these patients in these latter 2 cohorts were high risk patients. And that's what the time to biochemical progression looks like. So as I say, over 95% control in this high risk population. And then finally, just a couple of slides about where the MR-Linac helps us to go in prostate cancer. You can see from the flow of this slide that we're on a journey, and we want to test how low we can go in prostate cancer. And if you wanted to do that, I would wager that you want to do that with optimal image guidance, which is MRI. You'd want to monitor the patient and prostate position while you're treating, and you want to be able to change where the dose goes on a daily basis, which is something we can't normally do with prostate radiotherapy. So our HDR brachytherapy colleagues are ahead of the game here. They've been testing the ultimate hyperfractionation. Can we do it all in one day? And the answer sadly appears to be no, that if you give a single fraction of radiotherapy, it doesn't work very well. 19 gray 1 fraction showing very poor levels of biochemical control, in contrast to the 2 fraction approach here. There are 2 MR-guided radiotherapy machines on the market. So the ViewRay Meridian, which has had more clinical experience and has some advantages in that it does gating already. And the Elekta MR-Linac, which is what we have at the Marsden and what's available at the Christie Hospital, which has a stronger magnet, so slightly better imaging. And it's been an academic partnership, so developed in partnership with the physicists and the clinicians at Utrecht Medical Centre. And so utilising this new machine, we've set up a new trial at the Royal Marsden called Hermes, which stands for Hyperfractionated Expedited Radiotherapy for Men with Localised Prostate Cancer. And in Hermes, we're testing whether we can drop down from 5 fractions down to 2 fractions. So it's a randomised, currently single centre study where we're seeing whether we can safely and effectively deliver 2 fraction radiotherapy to the prostate. This was our first patient, so you can see that I very carefully picked one where the cancer was a long way away from the rectum and the urethra, so that's partly cheating, but it was easy to see his tumour, and we could very effectively boost the dose to that area. You can see the red hot dose here surrounding the tumour lesion here outlined in the white contour. And so far this patient, he's nearly a year on, he's doing very well without any remaining side effects from his treatment. So in conclusion, early prostate cancer is curable, often with few or no side effects. SBRT in 5 fractions may become the standard of care in the future, particularly if PACE-B reports favourably next year. Focal boost radiotherapy is likely to have an increasing role. I think there's still a role for treating the whole prostate to a lower dose, but certainly dose escalating the tumour makes sense, it's logical. And we and others are currently testing 2 fraction SBRT, the other trials going on in New York and in Toronto. And at the moment, 20 fractions remains the standard of care in the UK, but watch this space. I anticipate that could change in the future. Thank you very much for listening. Stop sharing. There we go.
Perfect. That was brilliant. Thank you so much. And a real whistle-stop tour of what we're doing at the moment in early prostate cancer treatment. I think that was really valuable. Thank you. Certainly the history lesson about why we fractionate, I had no idea. I think that's amazing. I love things like that happening in history.
Yeah, it's amazing how one experiment, which was interpreted correctly for what it's testing, can lead you off on a sort of path that takes you 100 years to get back from. So and that'd be a lesson to all of us.
Slowly rowing it back, as you said. Yeah. So I have to apologise to everyone for issues that we've been having with the chat. So I'm not 100% sure that everyone's still been able to give us questions. But we do have one from Dan. So he's interested in sort of the erectile dysfunction and GI toxicity.
Yeah.
Is there any data on toxicity, particularly the sort of the psychosexual impact, specifically in men who have sex with men, who might have very different concerns regarding sexual function? Is that a group that's being looked at specifically?
Yeah, that's a great question. So it makes me think of some of the early trials. Even the questions we asked were very specific to vaginal intercourse. That's thankfully been improved in the EPIC 26 now. So the questionnaires we've been giving out for PACE are not specific to sexuality. I'm not aware of any specific research looking into that. So the questions we ask are about strength of erections and erections sufficient for intercourse. It doesn't specify obviously gender for that. But I think that's a really important area that probably we do need to do more research on. I think overall sexual function is not paid much attention to. It's the most numerous side effect we see from radiotherapy, or at least it's the most numerous side effect that men who've had radiotherapy have. I think there's a separate piece of work to determine how much of that is the radiotherapy and how much of it is just the burden of being diagnosed with cancer and perhaps that not being top of your list for a while. In an aging population. So I think those are really interesting issues. And part of the motivation for doing focal boost and de-escalation is that we don't really know which tissue creates erectile dysfunction after treatment, whether it's the neurovascular bundle, whether it's the internal pudendal artery, whether it's the penile bulb. And so we felt that if we could de-escalate everything apart from the tumour, then we might start to spare some of that sexual function. So yeah, interesting. It'd be good to see some specific data in that area.
Thank you. That's a really interesting answer. And again, I didn't realise we didn't know which bit you shouldn't be hitting.
No, we don't.
With the radiotherapy. Great, yeah. Fantastic. Lovely. We've got another question for Hilary. I guess the question that I had with the approach that we're taking with radiotherapy now, are we moving away from surgery as a first-line treatment option? Obviously, you're going to have some bias as a clinical oncologist anyway, but it seems to me, as you're lowering toxicity with radiotherapy, with these approaches, it seems to me that surgery is becoming a less and less attractive option.
Yeah, so amongst friends, obviously. Yeah. I think we've historically always parroted the truth that surgery and radiotherapy is just as likely to cure your cancer. And I think that's probably still true, although with surgery you've got a higher chance of needing radiotherapy than vice versa. I think there is now a clear water between the two in terms of toxicity, because surgery, they've had some innovation with robotic surgery, but that's not really made a big impact on the toxicity. Whereas with radiotherapy, we've got a clear message that the toxicity's got less. So either it wasn't equivalent before, or it isn't now, or vice versa. But I'm totally biased. I think radiotherapy is a great treatment. So you probably have to ask a surgeon for the other side.
That's a very diplomatic answer, thank you. And we'll make sure no urologists get the password to get into this. Thank you. I don't think we've got any other questions specifically for you, but welcome to join in. Jenny's got a question for you, Hilary, if you don't mind unmuting. So I don't know if you've seen it, but she's said that she's had some experience with olaparib in different patient groups, i.e. probably the group that we're all most familiar with, which is using it in gynecological cancers, obviously specifically BRCA-mutated ovarian cancer. She's found that fatigue was a real limiting factor, particularly at the higher doses. And have you found you've needed to dose de-escalate in the prostate cancer group? And I guess specifically what the addendum to that is, what is making you de-escalate your doses?
Yeah, thanks, Ali and Jenny, for the question. I was just starting to write a very long answer, so I'm glad that you've come to me just to speak, because then I can stop typing furiously. So the issue is that we have not had a great experience with olaparib thus far in off-study patients. And I think the reason for that is that we are treating men far too late. So not only are they old and probably frailer, but as I mentioned, they have often had 2 lots of taxanes, if not possibly 3. They've had radium, they've got really advanced disease, and their bone marrow is already knackered. And we've had to dose reduce everybody we've given it to so far, and they've tolerated it really badly. And I've not yet really seen anyone that's had a brilliant response. And I think that's because of when we're treating. And I think that's why it's so important to try and get people tested earlier, because we can't treat them until we've got the test. And if we can't do the test until we're really desperate and at the sort of end stage, then we'll be able to give them olaparib, but I think it's going to be too late. So I think it's too early to say what will happen in the normal situation, because I would like to think we would start being able to use this a lot earlier, but I actually think we will struggle. I think we've had such a long time of having Abi and Enza and all of these ones that are tablets that are really well tolerated compared to chemotherapy that's more troublesome. And I think in our heads we think, oh, it's just a tablet, it'll be fine. And I think it's not. So I think we will have to be very careful who and how we treat with olaparib. But yes, I think even if we catch them earlier, we will probably still struggle with fatigue and anemia.
Thanks, Hilary. Yeah, who, how, and when, I guess, are the questions to answer with olaparib. And anemia seemed to be a particular issue in the cohort that I treated when I was in your clinic. But we did see it in the ovarian cohort when I was doing ovarian cancer with olaparib. So it might just be a West of Scotland thing where no one has enough folate or vitamin B12 in their diet. So firstly, I'd like to say a massive thank you to both Hilary and Alison for some really fantastic talks. These will be available online going forward.